The moment a patient walks through the door, a clock starts ticking, doesn't it? And there's this immediate cognitive challenge.
Absolutely.
It's not just knowing all the diseases, the huge list. It's about operating in that gray zone, where things aren't clear, data might be missing.
That's the core difficulty.
So today we're diving deep into that, into the heart of clinical medicine, really. How do doctors turn all that messy human information into actual decisions?
It's fundamental. And it's why, even with all our science, medicine is still an art. Sir William Osler said it best, didn't he? Over 100 years ago.
What was the quote again?
Medicine is a science of uncertainty and an art of probability. The science gives us facts, sure, but the art. That's the skill, the judgment, the experience needed to navigate all that unavoidable uncertainty, that guesswork beneath every symptom.
And ignoring that uncertainty is dangerous.
Extremely dangerous.
Yeah.
Clinicians do it at their peril.
So our mission today is to look at the blueprint for mastering that art, using the framework from Harrison's internal medicine text. We want to understand the internal machinery. How do you get from symptoms and tests to a plan?
Harrison's really lays out 3 pillars, 3 skills modern doctors absolutely have to master.
Okay, what are they?
First, expertise in clinical reasoning, not just what to think, but really how to think.
Right, the process.
Second, mastering the rational use and interpretation of diagnostic tests, knowing when to order what and what the results actually mean.
Sure so.
And third, integrating the best available research evidence, what we usually call evidence-based medicine or EBM, with a specific patient sitting in front of you.
Makes sense.
So we're going to break down all 3, starting with that first pillar, the art of thinking itself.
Okay, so clinical expertise. It's funny, we talk about master clinicians, but it's so hard to define objectively, isn't it?
It really is.
Like, in chess, you have grandmasters, clear rankings. Sports have objective measures. But in medicine, after training, it just becomes subjective.
It speaks to the complexity, I think. We all know those amazing diagnosticians in hospitals, the ones who figure out the really tough cases.
Yeah, the go-to people.
But often, they can't even explain exactly how they did it. Their thought process is kind of opaque, which makes it really hard to teach or replicate systematically.
And that skill isn't always transferable, is it?
No, not at all. Harrison's makes that point. An expert in, say, complex cardiomyopathy might be completely lost dealing with something common like neutropenic fever, maybe even worse than a junior resident. The expertise is very, very specific, localized.
So if it's not just knowing more facts, what makes up this expertise?
Well, it's a package deal. A big part is definitely cognitive integration. Linking vast knowledge with subtle cues, interpreting tests, seeing patterns.
The thinking part.
Right. But it also includes non-cognitive things, like the fine motor skills for procedures and communication, coordinating care, hugely important. For this discussion, though, we're really drilling down on the cognitive side. The decision-making happening inside the head.
Which must be incredibly hard to study, like trying to map smoke, as you said.
Tremendously hard. Researchers try things like asking doctors to think aloud during simulations.
Does that work?
It might change the process itself, Others work backward, analyzing diagnostic errors to see how reasoning went wrong, trying to figure out how doctors should think, maybe not how they always do.
So where does our understanding come from?
A lot of it actually comes from cognitive psychology, behavioral economics, fields outside medicine that study problem solving. That's why we often use these general cognitive models.
Okay, so let's talk about those models. The main one seems to be this dual process theory, thinking fast versus thinking slow.
Exactly. That's the core idea. We operate on a spectrum between 2 modes of thinking.
Intuitive versus analytic.
Precisely. System 1 is the intuitive mode. It's fast, almost effortless. It relies heavily on pattern recognition, mental shortcuts, heuristics, we call them.
Like muscle memory for the brain.
Kind of, yeah. The brain quickly pulls up these deeply learned associations. Harrison's gives that example. Black woman plus Hiller adenopathy equals sarcoid.
Instant diagnosis, almost.
Right. And the expert often can't even list the steps. It just pops into their head. Minimal effort. That's the gut feeling.
And system 2, that's the opposite.
That's the analytic reasoning. System 2 is slow, deliberate, methodical. It takes real conscious effort.
Like when you're first learning something.
Exactly. It's what students do when they read the textbook chapter, listing out every single cause of a symptom. Experts use it too, though. When a case doesn't fit a pattern or it's outside their main area, or, and this is key, when they're deliberately double-checking a system 1 hunch.
So they're not totally separate.
No, it's a continuum. A master clinician is constantly shifting back and forth between them.
Let's use that Harrison's example of hemoptysis coughing up blood in a 46-year-old man. It really shows how System 1 uses context to leap ahead.
It's a great illustration. Scenario 1.
Yeah.
He's healthy, a non-smoker, just had viral bronchitis, now has blood-streaked sputum.
Low risk.
Right. The pattern screams acute bronchitis. Minor inflammation. A simple chest x-ray is probably enough. Decision made fast.
But scenario 2, same symptom, but different context. Now he's a heavy smoker, 100-pack years, and he's lost weight.
Instantly different. That history triggers the high-risk pattern for lung cancer.
Completely changes the approach.
Totally. The experienced doctor knows immediately. This needs a full workup. Forget the simple x-ray. We need CT scans, maybe cytology. System 1 jumps straight to that higher level of concern.
And the third scenario brings in the physical exam. Same age, same hemoptysis, but he's an immigrant, and you hear a specific heart murmur.
A diastolic rumble. That murmur is the key piece of context. It shifts the pattern again.
To what?
It strongly suggests rheumatic mitral stenosis, the heart valve disease,
Mm.
and the hemoptysis. Probably from lung congestion because of the heart problem, not a primary lung issue.
So the next step isn't a chest CT.
No, the pattern immediately points to needing an echocardiogram, an ultrasound of the heart. Same initial complaint in all three, but System 1 pattern matching directs the whole diagnostic path differently each time, instantly.
Okay, System 1 is fast, efficient. So why does Harrison's warn us so much about relying on it? Don't we want doctors to trust their gut?
Ah, that's the crucial tension. Pattern recognition is efficient, yes, but relying only on it and skipping the System 2 check, that leads straight to the biggest cognitive trap, premature closure.
Meaning, jumping to conclusions too fast.
Exactly. It's when you latch onto the first plausible diagnosis and just stop thinking about alternatives. Harrison says it's the #1 cause of diagnostic errors.
And they give that really sobering case example, the 45-year-old man in the ED.
It's a tragic case, really highlights the danger. He comes in 3 weeks of flu-like symptoms, but also significant shortness in breath, productive cough. The ED doc immediately uses a standardized URI assessment form, a classic System 1 shortcut, right? Quick exam, no fever, clear chest. Diagnosis, acute bronchitis. Prescribes a cough suppressant, sends him home.
So the form itself became a kind of blinker.
Precisely. The structured form encouraged premature closure.
Yeah.
The focus was just on confirming the simple, common diagnosis bronchitis.
And what got missed?
The things that should have triggered System 2 analysis, the severity of the breathlessness, the 3-week duration, those suggest something more serious is going on.
And the outcome?
The patient collapsed overnight. Died from a massive heart attack, a posterior wall MI. The error wasn't lack of knowledge about heart attacks, it was the failure to do that second step, diagnostic verification. Asking, does acute bronchitis truly explain everything I'm seeing, especially the severe and prolonged symptoms?
Wow. Okay. That really drives home why we need to understand these mental shortcuts, these heuristics. They're useful, but they have built-in failure points.
Exactly. They're efficient, but prone to systematic errors or biases. Harrison's focuses on 4 key ones in diagnosis.
Let's unpack them. What's the first one?
The representativeness heuristic. This is basically classic pattern matching gone wrong.
How so?
You diagnose based on how closely the patient matches your mental picture, your prototype of a disease. The big error here is overestimating the chance of a rare disease just because the patient looks like the textbook description.
Like the pheochromocytoma example.
Oh.
Headache, palpitations, sweating. Must be that rare tumor.
Right. You see the classic triad and jump to pheo, even though it's incredibly rare. You're ignoring the base rate, the actual low frequency, the pretest probability. Millions have those symptoms from common things like anxiety.
So the compelling pattern overrides the statistic.
It does. And the flip side is also true. You might underestimate common diseases when they present atypically because they don't fit the standard pattern.
Okay, what's the second heuristic?
The availability heuristic. This one is all about ease of recall. How easily examples spring to mind.
Meaning memorable cases have more influence.
Exactly. Our memory isn't statistical. It's biased towards vivid, recent, or emotionally charged events. So, if a doctor recently saw a patient with a simple sore throat who turned out to have leukemia, a very rare but catastrophic presentation,
That case sticks in their mind.
it's highly available.
Right.
So the next time they see a sore throat, even though leukemia is astronomically unlikely, that rare possibility gets weighted far too heavily in their thinking, just because the memory is so strong.
I can see how that happens. Okay, third one, anchoring.
We touched on this. The anchoring heuristic is about sticking too rigidly to your initial impression.
Like cognitive inertia.
That's a good way to put it.
Yeah.
You make an initial judgment about the probability of a disease, and then even when new data comes in, like test results, you don't adjust your estimate enough.
Can you give an example?
Sure, you judge someone's risk of heart disease as high because of strong family history. That's your anchor. Then they have a perfectly normal, high-quality stress test. Logically, their risk should drop significantly.
But anchoring means?
You don't lower it enough. You're still stuck on that initial high-risk label, underweighting the impact of the negative test. You fail to follow the logic of Bayes' theorem, which we'll get to.
Right. And the last one, simplicity, or Occam's razor.
The simplicity heuristic. We prefer the simplest explanation that covers the main facts. Find one diagnosis that fits most things.
Sounds reasonable usually. What's the error?
The error is neglecting unexplained significant findings. You latch onto the single, simple diagnosis and kind of brush aside the one or two symptoms that don't quite fit.
Instead of considering maybe two diseases are happening, or a more complex single disease.
Exactly. You sacrifice completeness on the altar of simplicity. You stop searching too soon.
So when these System 1 heuristics might lead us astray, we need to shift gears. Engage System 2, using that more formal hypothetico-deductive model.
Right. This is the deliberate step-by-step process. It starts with hypothesis generation, making an initial list of possibilities based on the first bits of information.
Then what?
Then comes diagnostic refinement. As you gather more history, do the physical exam, you test that new info against your mental models of the diseases on your list. Some possibilities become more likely, others less so.
Guiding the next steps.
Leading to a focused physical exam aimed at testing your current leading hypotheses. And finally, the crucial step we discussed, diagnostic verification.
Which involves checking for adequacy and coherency. Can you explain those terms a bit more?
Sure. Adequacy means your final diagnosis has to account for all the significant findings. You can't just ignore the bits that don't fit your preferred theory.
Okay. And coherency.
Coherency means the signs and symptoms must make biological sense. They must be consistent with the known pathophysiology of the disease you're proposing.
Like, if you suspect diverticulitis, you expect certain lab results or tenderness.
Exactly. If you suspect acute diverticulitis because of abdominal pain, the coherent findings would be things like localized tenderness, maybe fever, maybe an elevated white blood cell count. If the labs are totally normal and the pain is vague and diffuse, your hypothesis lacks coherency. It doesn't hang together physiologically. You need to rethink.
This really highlights something often overlooked: the importance of negative findings, things that aren't there.
Hugely important. The absence of an expected sign or symptom actively helps you rule things out, reducing uncertainty. For instance, chest pain that is definitely not worse with exertion makes typical angina much less likely, no goiter, no tremor, makes hyperthyroidism less likely in someone with new atrial fibrillation. Negatives are powerful data points.
But sometimes probability takes a back seat, right? Harrison's talks about diagnostic imperative.
Yes. In certain acute, high-stakes situations, you have to prioritize ruling out rare but potentially catastrophic conditions, even if they're statistically less likely. Prevalence doesn't matter as much.
Like the aortic dissection example.
That's a classic one. A patient comes in with severe tearing chest pain. An MI is much more common, but missing an aortic dissection can be fatal almost instantly, especially if you give treatments for MI like blood thinners.
So the imperative is?
The imperative is to actively look for signs of dissection. Check blood pressures in both arms, feel for pulse differences, ask about specific pain characteristics, even if you think MI is more probable. You have to rule out the catastrophe first.
Okay, so we have these thinking processes, heuristics, biases. And the main tool to cut through the uncertainty is diagnostic testing.
Right. And remember, test here means any piece of information. History detail, exam finding, lab result, imaging. It's all data used to revise probabilities.
And we tend to simplify the results, don't we, into positive and negative.
We often do, for practical purposes. But to know what positive or negative actually means for that specific test, we need to compare it to the truth, the gold standard.
The definitive way to know if the disease is really present or absent.
Exactly. And we lay this out in the standard 2x2 table, comparing the test result, positive, negative, against the true disease state, present, absent.
Which gives us 4 possible outcomes.
Correct. You have the ones we want.
Yeah.
True positives, TP, the test is positive, and the patient really has the disease. And true negatives, TN, test negative, patient is healthy.
And the errors we want to avoid.
False positives, FP test is positive, but the patient is actually healthy. And false negative's FN test is negative, but the patient tragically does have the disease.
And from these 4 boxes, we get the 2 fundamental properties of any test: sensitivity and specificity.
That's right. Sensitivity is the true positive rate. Ask, of all the people who genuinely have the disease, what percentage does this test correctly identify as positive?
Okay. And specificity.
Specificity is the true negative rate. Ask, of all the people who are genuinely healthy, what percentage does this test correctly identify as negative?
And there are those handy mnemonics: sun out and steep in.
Essential rules of thumb. Sin out. A test with high sensitivity, when N negative, helps rule out the disease. A negative result from a very sensitive test is reassuring.
Makes sense. If it's good at catching it, a negative means it's likely not there.
Precisely. And stat pin. A test with high specificity, when P-positive, helps rule in the disease. A positive result from a very specific test is convincing.
Because it's unlikely to be positive in someone healthy.
Exactly.
But calculating these depends on where we set the bar, right?
Right.
The cut point for calling a test positive.
Absolutely. And setting that cut point involves an unavoidable trade-off.
How so?
If you make the criteria for a positive test really strict, a high cut point, you'll increase specificity, fewer false positives. But you'll inevitably decrease sensitivity. You'll miss more true cases, more false negatives.
And if you lower the bar, make it easier to test positive.
You'll increase sensitivity, catch more true cases. But you'll decrease specificity, get more false positives among the healthy. You generally can't push both up simultaneously unless the test gets fundamentally better.
This trade-off is visualized perfectly by the receiver operating characteristic curve, the ROC curve. Can you walk us through that? It sounds complicated, but the visual is powerful.
It is powerful. The ROC curve plots the test's performance across all possible cut points. The y-axis is sensitivity, true positive rate, and the x-axis is 1 minus specificity, which is the false positive rate.
So each point on the curve is a different cut point choice.
Exactly. Each point shows the sensitivity-specificity pair you'd get if you chose that particular threshold to define positive.
And what tells us if the test is any good overall?
The shape and position of the curve. There's a diagonal line from the bottom left to the top right corner. That line represents a useless test, basically a coin flip, 50-50 chance.
No better than guessing.
Right. The further the curve bows up and to the left towards the top left corner, the better the test is at discriminating between people with and without the disease.
And we measure that bowing how?
With the area under the curve, the AUC. An AUC of 0.5 is that useless diagonal line. An AUC of 1.0 would be a perfect test, discriminating perfectly. Most tests fall somewhere in between.
So the AUC gives you the overall diagnostic power. But how does a clinician pick which point on that curve, which cut point, to actually use in practice?
That choice depends entirely on the context. Specifically, the relative harms of a false positive versus a false negative for that particular disease and treatment.
Can you give examples?
Sure. Think about screening newborns for phenylketonuria, PKU. The disease is devastating if missed, but the treatment, a special diet, is relatively safe and inexpensive.
So you want to catch every case.
You want maximum sensitivity. So
Yeah.
you choose a cut point on the ROC curve way up towards the top, even if it means accepting a higher false positive rate, more babies needing retesting. Missing a case is the worst outcome.
Okay. What about the opposite scenario?
Consider testing for a cancer, where the treatment itself, like aggressive chemotherapy, is highly toxic and risky. Here, a false positive, telling a healthy person they have cancer and subjecting them to chemo, is a terrible outcome.
So you prioritize specificity.
Exactly. You choose a stricter cut point, further to the right on the curve, to minimize false positives, even if it means you might slightly lower sensitivity and potentially miss a few very early or mild cases. The harm of a false positive outweighs the harm of a slight delay in diagnosis for some.
Okay, that makes sense. Now, putting it all together, we have a pre-test probability, we have a test with known sensitivity and specificity. How do we formally update our probability? That's Bayes' rule, right? This helps fight that anchoring bias.
Precisely. Bayes' theorem provides the mathematical framework for rationally revising our probability estimate after getting a test result. It calculates the post-test probability.
Which is the probability of disease after, the test result.
Correct. And it requires 3 key inputs. The pretest probability, your best guess before the test, and the test sensitivity and specificity.
Let's use that Harrison's example again. The 64-year-old woman with atypical chest pain. Let's say, based on everything else, we estimate her chance of having coronary artery disease, CAD, is 50-50. So pretest probability is 0.5.
Okay.
And she undergoes a test with, say, 90% sensitivity and 90% specificity. What happens if the test is positive?
Plugging those numbers into Bayes' formula, a positive result dramatically increases her post-test probability of having CAD up to about 0.90 or 90%.
And if it's negative?
A negative result would drop her probability way down to around 0.10 or 10%. It forces a quantified update, moving away from vague feelings towards a more precise estimate of certainty.
And you mentioned Harrison's emphasizes using post-test probability instead of predictive value. Why is that term preferred?
Predictive value, positive predictive value, PPV, and negative predictive value, NPV, is problematic because it sounds like an intrinsic property of the test itself. But it's actually highly dependent on the prevalence of the disease in the population being tested.
Ah, so the same test gives different predictive values in different groups.
Exactly. A test will have a much higher PPV in a high-risk clinic population, where prevalence is high, compared to a low-risk screening population, where prevalence is low, even if its sensitivity and specificity are identical. Post-test probability avoids this confusion. It's always about the probability for this patient, given their pre-test risk and the test result.
Okay. Now, doing days calculations constantly isn't practical, so clinicians often use likelihood ratios, right?
Yes, likelihood ratios, LRs, are a fantastic way to simplify Bayesian updating. An LR summarizes the diagnostic power of a test result into a single number.
How's it calculated?
It's the ratio of the probability of getting that specific test result, say positive, in someone with the disease, divided by the probability of getting that same result in someone without the disease.
So a high LR means the result is much more likely in diseased people.
Correct. The LR positive, LR plus, tells you how much a positive test increases the odds of disease. An LR plus greater than 10 is generally considered strong evidence to rule in the disease. Usually means the test has high specificity.
And the LR negative?
The LR negative tells you how much a negative test decreases the odds of disease. An LR less than 0.1 is generally considered strong evidence to rule out the disease. It usually means the test has high sensitivity. Send out.
These LRs act like multipliers on our initial odds.
That's exactly right. And this multiplication is visualized really well using the nomogram shown in Harrison's.
Describe the nomogram for us. How does it work?
It's a simple but elegant tool. It has 3 vertical lines. The left line represents the pretest probability. The middle line represents the likelihood ratio for the test result you got. And the right line shows the resulting post-test probability.
And you just draw a line.
You use a straight edge. You place it on your estimated pretest probability on the left scale, pivot through the likelihood ratio for your test result on the middle scale, and wherever the line crosses the right scale, that's your post-test probability. It does the calculation visually.
And Harrison's uses it to compare 2 different heart tests for that patient with a 50% pretest probability of CAD.
Right, it shows the difference clearly. If the patient has a positive standard exercise treadmill test, which has an LR plus of about 4.0,
you draw the line from 50% through 4.0.
and it hits the right scale at about 80% post-test probability, a significant jump.
But what about the better test, the SPECT perfusion study?
That has a higher LR plus around 9.0. So starting again at 50% pretest probability, you draw the line through 9.0 on the middle scale.
And where does it land?
It lands much higher, around 90% post-test probability. The nomogram visually confirms that the SPECT test provides much stronger evidence to rule in the disease in this uncertain patient.
So the big clinical takeaway from all this Bayesian thinking is about when testing is most impactful.
Absolutely. The largest change in probability, the biggest reduction in uncertainty, happens when you are most uncertain to begin with. That sweet spot is usually when the pretest probability is in the intermediate range, say between 30% and 70%.
Why is that?
Think about it. If your pretest probability is already very low, like 5%, even a moderately good positive test might only bump you up to, say, 20% or 30%. That might not be enough to change management or warrant risky interventions.
Still mostly likely they don't have it.
Right. And conversely, if your pretest probability is already very high, like 95%, a positive test might push you to 99%, but you are probably going to treat them anyway. A negative test might lower it, but maybe only to 80%, still high. The test result makes the biggest difference when you're genuinely on the fence.
But we need to be realistic. Bayes' rule, as used, often makes simplifying assumptions.
It does. A key one is conditional independence. The math assumes that the result of one test doesn't influence the probability of the result of a subsequent test, beyond both being related to the underlying disease.
Which isn't always true in biology.
Often not true. Many tests measure related physiological processes. Also, sensitivity and specificity themselves aren't always completely independent of disease prevalence or severity. The treadmill test example is good. It's much more sensitive for severe three-vessel CAD than for mild single-vessel disease. The real world is messy.
Okay, so moving beyond single tests and simple Bayesian updates, complex cases need more sophisticated tools.
Definitely. When you have multiple pieces of information, history, exam, several tests that might overlap or interact, simple Bayes isn't enough. We need multivariable statistical models.
Like logistic regression.
Often, yes. These models can simultaneously consider many variables, figure out the independent contribution of each one, and assign appropriate mathematical weights to predict an outcome, like the probability of having a disease.
These require computers or calculators, though.
They do. They're computationally intensive, but they allow for a much more nuanced risk assessment than just looking at factors one by one.
And Harrison's highlights the Wells criteria for pulmonary embolism, PE, as a really successful example of a validated multivariable model.
It's a classic. It takes several clinical features, signs of DVT, heart rate, recent surgery, history of PE. Whether PE is the most likely diagnosis assigns points to each.
Right, like 3 points for clinical signs of DVT, 1.5 points for heart rate over 100.
Exactly. You sum the points, and the total score stratifies the patient into a clear pretest probability category for PE. Low, intermediate, or high.
And this standardizes the assessment.
It does. It forces a systematic consideration of validated risk factors, rather than just relying on Gestalt. But Harrison's makes a crucial point here. Validation is everything.
Meaning?
A risk prediction model developed in one population needs to be tested and proven accurate in a different, independent population before you can trust it clinically. An unvalidated model is like an unproven drug, potentially dangerous.
This leads us neatly into the cutting edge, formal decision support and artificial intelligence, AI. We hear so much about AI in medicine now.
The field is moving incredibly fast. We're seeing different types of AI emerge. Machine learning and deep learning are showing real promise in pattern recognition tasks, reading X-rays, analyzing skin lesions from photos, interpreting ECGs.
What about things like ChatGPT, the large language models, LLMs?
Those fall under generative AI. They might have roles in, say, summarizing complex patient notes, drafting discharge instructions, maybe even helping clinicians search medical literature more efficiently.
But there's also a lot of caution in Harrison's about AI. Why the hesitation? Terms like model confabulation and automation bias come up.
The caution is vital because the hype often runs ahead of the proven safe clinical utility. Model confabulation is a huge worry. The AI can essentially hallucinate, generate plausible sounding but completely incorrect information.
Like making up a lab result or misstating an allergy.
Exactly. And it can present this false information with absolute confidence, making it hard to detect. The potential for harm is enormous.
And automation bias is the human side of the problem.
It is. It's our tendency to overtrust computer outputs, to defer to the machine, even when the information seems wrong or contradicts our own judgment. We might stop thinking critically because the AI said so.
So the tool meant to help could actually introduce new errors.
That's the risk.
Yeah.
It could undermine the very clinical reasoning it's supposed to support. So rigorous independent validation in real clinical settings is non-negotiable before we widely deploy these tools. The clinician must remain the final checkpoint, critically evaluating the AI's output.
Okay, let's shift to the ultimate goal. Using all this information for personalized decision-making. Harrison's draws a useful distinction here.
Yes, it separates it into two levels. First, there's precision medicine. This is about tailoring risk assessment and treatment benefits based on an individual's unique biology, genomics, biomarkers, specific comorbidities, trying to find the scientifically optimal path for that person.
And the second level.
That's shared decision-making. This is about bringing the patient's own preferences, values, and life goals into the conversation, what matters most to them.
Like the example of delaying surgery for a wedding.
Exactly. Maybe the best medical option involves short-term risks the patient finds unacceptable because of other life priorities. Shared decision-making respects that the goal isn't just adding years to life, but life to years, as defined by the patient.
Now, experienced clinicians have seen a lot. It must be tempting to just rely on personal experience when making recommendations. Why does Harrison's argue against that?
Because personal experience, especially for chronic diseases, is riddled with bias and the counterfactual problem.
Meaning you can't know what would have happened.
Precisely. If you treat someone's high blood pressure and they don't have a stroke for 10 years, you can't know the drug prevented it. Maybe they wouldn't have had a stroke anyway. Most people don't have the bad outcome in any given time frame.
So anecdote isn't reliable evidence of effectiveness.
Not at all. True therapeutic effectiveness has to be shown statistically in large groups, ideally to controlled trials that minimize bias. Individual experience is just too noisy and prone to misinterpretation.
Which brings us back squarely to evidence-based medicine. EBM, can you recap the core steps?
EBM is a structured approach. Step 1. Formulate a clear clinical question based on the patient's problem. Step 2. Search the literature efficiently to find the best available evidence answering that question. Step 3. Critically appraise that evidence for its validity, how well was the study done, and applicability. Do the results apply to my patient? And step 4. Integrate the appraised evidence with your clinical expertise and, crucially, the patient's unique circumstances and values.
And since digging through primary studies is time-consuming, clinicians often rely on synthesized evidence.
Yes, ideally systematic reviews and meta-analyses. Systematic reviews try to find all relevant studies on a topic using explicit methods. Meta-analysis then uses statistical techniques to pull the results of multiple individual studies, often randomized trials.
What's the big advantage of meta-analysis?
Power. It can combine data from several smaller trials that, on their own, might not have had enough patients to show a statistically significant effect. They are underpowered. By pooling the data, a meta-analysis can sometimes reveal a true benefit or harm much earlier.
Like the streptokinase example for heart attacks.
That's a famous one. Meta-analysis showed the benefit years before the single, huge trials confirmed it. Gives us the most statistically robust estimate of the treatment effect.
Speaking of effect size, we often hear the term number needed to treat, NNT. What does that tell us?
The NNT is a measure of treatment efficiency. It's calculated as 1 divided by the absolute risk reduction, ARR.
Can you illustrate?
Sure. If a drug reduces the risk of an event from, say, 12% in the control group to 8% in the treated group, the absolute risk reduction is 12% minus 8%, which equals 4%, or 0.04.
So the NNT is?
1 divided by 0.04, which is 25. It means you'd need to treat 25 people with that drug compared to placebo for that duration to prevent one additional event.
And it helps compare efficiency.
Yes, and it highlights how efficiency depends on baseline risk. If you use the same drug in a lower risk group, where the event rate was only 4% to begin with, the ARR might only be 1% and the NNT would jump to 100. It takes treating many more low-risk people to prevent one event. It's useful for communicating risk and benefit.
Where does this evidence come from primarily? Harrison's contrasts randomized controlled trials, RCTs, with observational registries.
RCTs are considered the gold standard for establishing cause and effect because randomization minimizes selection bias. They have high internal validity. You can be confident about the result within the study population.
But they have downsides.
Sometimes they lack external validity or generalizability. The strict inclusion-exclusion criteria mean the study population might not fully represent the diverse patients we see in everyday practice. Older patients, people with multiple conditions, etc.
And observational registries.
Registries collect data on large groups of patients in real-world settings without randomization. They often have better generalizability because they include a broader range of patients.
But they're weaker for causality.
Much weaker. They're prone to confounding hidden factors that might explain the observed association. But they're essential for studying things where RCTs aren't feasible or ethical, like long-term effects of exposures, and for tracking outcomes in routine care.
Finally, how does all this EBM get translated into practice? Through clinical practice guidelines.
Right. Guidelines are systematically developed statements from expert panels designed to assist clinicians and patients with decisions about specific conditions. They aim to improve care quality by promoting evidence-based practices.
But they're guidance, not rules.
Exactly. They are normative, suggesting a standard of care, but always need to be applied thoughtfully to the individual patient context. And Harrison points out a significant limitation.
Which is?
Even in recent high-quality guidelines like those in cardiology, a surprisingly small percentage of recommendations, often less than 15%, are actually based on the highest level of evidence. Multiple large RCTs or meta-analyses.
So much of medicine still operates in areas without definitive trial data.
A huge amount. It underscores that clinicians constantly have to integrate the available evidence, imperfect as it may be, with sound clinical reasoning and patient values to navigate that inherent uncertainty.
Okay. We've taken a really deep dive into the mechanics of clinical decision-making, guided by heresies. Let's try to summarize the absolute key takeaways.
All right. I think 4 main points stand out. First, clinical practice is fundamentally about managing uncertainty. This requires skillfully balancing fast, intuitive System 1 thinking with slow, deliberate System 2 analysis.
Second, those mental shortcuts, the heuristics like representativeness and anchoring, are essential for efficiency, but are also major pitfalls. They lead to predictable biases that must be actively checked and verified.
Third, making sense of diagnostic tests isn't just about the result. It demands understanding sensitivity, specificity, and how to use Bayes' rule or likelihood ratios to integrate the result with the pretest probability.
And remembering that testing gives the biggest bang for your buck when uncertainty is highest, that intermediate pretest probability zone.
Exactly. And fourth, while modern tools like validated risk prediction models, example Wells criteria, and emerging AI offer powerful support, they come with risks. AI needs rigorous validation to avoid harm from confabulation or automation bias.
And underpinning all of this is the framework of evidence-based medicine, the continuous effort to blend the best research evidence, clinical expertise, and patient preferences, even recognizing that perfect evidence rarely exists for every question.
That's the ongoing challenge. And Harrison's makes an interesting point, drawing parallels to other fields like music or chess. It highlights that developing true mastery requires deliberate, effortful practice over years, often combined with personal coaching and feedback.
Which leads to a provocative final thought, doesn't it? Given how complex medicine is becoming, and with these powerful but potentially flawed AI tools arriving, how do we actually design medical training now? How do we ensure future doctors get that kind of intense, deliberate practice and personalized coaching needed to truly accelerate their journey from novice to genuine master clinicians?
That's the multi-billion-dollar question, isn't it? How do we cultivate that deep clinical wisdom in the age of algorithms? It's the fundamental challenge for medical education going forward.